internship, residency, and chief residency in internal medicine at Columbia. She stayed on for fellowship in digestive and liver diseases, during which time she published multiple papers on topics related to colon cancer screening, early onset colorectal cancer, and colonoscopy quality. She also earned a master's in patient-oriented research from the Department of Biostatistics at the Mailman School of Public Health. Dr. Kriegel joined the faculty of the Division of Digestive and Liver Diseases at Columbia University Irving Medical Center in 2020. She continues to be involved in trainee education as the Associate Program Director of the DLD Fellowship Program, and she participates in cross-campus colonoscopy quality initiatives as the Associate Director of Colonoscopy Quality for that division. And Dr. Kriegel is also fluent in Spanish. We also have Andrea Reyes. She's a senior health educator, Office of Community Outreach and Engagement at the Herbert Irving Comprehensive Cancer Center at Columbia University Medical Center. Andrea has an undergraduate degree in psychology and a master's degree in health and behavior studies from Teachers College, Columbia University. Andrea has expertise creating and delivering culturally relevant health promotion and disease promotion materials. For Columbia Cancer Center, she manages the health education program, delivers a suite of health education workshops in English and Spanish, offers outreach document translation services to the Columbia community, and offers her research expertise to investigators throughout the Cancer Center. And Kimberly Burke, the operations manager, Office of Community Outreach and Engagement at Herbert Irving Comprehensive Cancer Center at Columbia University Medical Center also. Kimberly holds a Bachelor of Science, a Master's of Public Health with concentration in nutritional science and environmental health from Boston University School of Public Health. Kimberly has several years of experience working in public health and community education. And in her current role as operations manager for the Office of Community Outreach and Engagement at Columbia's Cancer Center, she coordinates outreach projects, assists with event planning, and together with the COE, works closely with community partners to tailor education and outreach programs to the needs of the communities throughout New York City. I made sure I read all of that for you so you could see that we have an awesome team this evening that is going to share vital information with us. It's a well-rounded team. I just want to let you know right now is the time for you to make sure you get a piece of paper or your notepad and some pen so you could take some notes. You'll also be able to ask your questions verbally or you could put it in the chat. So without further ado, I present to you the team from Columbia University. Dr. Reyes, Andrea, and Kimberly, it's all yours.
Thank you very much, and thank you to everyone for being here this evening. Before we begin with Dr. Kriegel's presentation, I'd like to launch some questions up on the screen. You're going to see some questions pop up. They are based on the things that we're going to learn today in today's presentation. I would love if you can all just answer. They are true, false, and don't know questions. And it tells us a lot about what people know going into the workshops that we give. I know that there's someone, oh, there they go. They just popped up on the screen. Is there a way to answer? Let me see. Yes, and so we're going to leave this up like 2 or 3 minutes and have people respond. And once everyone's done, we'll pull it down and then we'll start with the workshop. Thank you so much. We are watching the questions come in. Thank you to all for responding. If you haven't started and you don't mind answering questions, please do. We would love to see your responses. All of these, of course, are anonymous. Okay, so we're going on 5 minutes with the poll up. I think maybe at most 1 more minute. If anyone needs more than a minute, please let us know and we'll keep it up an extra minute. I think we can end the poll now, if that's okay. Thank you all for answering. And again, thank you for having us. We're really excited to be able to provide this presentation for you today. I'm going to leave you in the hands of Dr. Anna Kreigel. Keep in mind that we are going to talk for a little while, and then we're going to leave plenty of time for all of you to answer, to get your questions answered. So what I'd like to ask you to do, if you can put your questions in the chat, you can do it during the presentation or afterwards, and I'll be reading the questions out of the chat and having Dr. Kreigel answer. You can also feel welcome to ask out loud, that can and come on camera and come on the microphone, or you can place your questions in the chat, but we'll go one by one and make sure everything is answered. Thank you very much. And Dr. Kreigel, it's all yours.
Okay, thank you. I'm going to share my slides. Okay, and everyone can hear me? Great. All right. So we're going to be talking about colon cancer screening and who's at risk, when you should be doing colon cancer screening, and and how to reduce your risk if there are other ways aside from screening. So thank you so much for having me. It's really a pleasure to speak with you all this evening. So first, some basics on what are the colon and the rectum, and then we'll talk about colon cancer, risks for colon cancer, who should be screened, what are the different screening tests, what are the differences, the advantages and disadvantages of all of those, and how to lower your risk for colon cancer. So some facts about colon cancer: it's the third leading cause of cancer and cancer deaths in the US among New Yorkers, and that's true of both women and men. And colon cancer is actually preventable. You can remove polyps during colonoscopy that prevents their growth in the future. Polyps are benign growths in the colon. They can grow, though. They can be precancerous. And so when we find them on colonoscopy, we remove them and thereby prevent colon cancer in the future. Screening for colon cancer has two purposes. It is to prevent colon cancer by finding and removing precancerous polyps, but also to detect colon cancer at an early stage when it's still treatable and even curable. So those are the two reasons that we do colon cancer screening. So some basics on anatomy about the colon and the rectum, because we're talking about colorectal cancer. The colon and the rectum are part of the digestive system. Food is digested from the mouth into the esophagus and goes into the stomach and the small intestine, where a lot of the digestion happens, and then moves to the colon, which is also known as the large intestine, or the large bowel is another term you might hear for it. The colon's job is to absorb water, and then waste, which is stool, moves through the colon and into the rectum and then gets deposited when you have a bowel movement. The colon is about 5 to 6 feet long, and that's the organ through which we do a colonoscopy. Colon cancer is a type of cancer that begins in the large intestine, or the colon. As I said, it usually begins as small clumps of cells called polyps that form in the colon, and then over time can grow and become polyps. Become cancer. And a polyp, this is a picture on the left. It's a little growth sometimes with a stalk, or sometimes it's flat against the colon. And then a colon cancer is a larger mass. And both of these views are views on colonoscopy or on a picture of the colon. And then rectal cancer is specific to the rectum, but very similar to colon cancer. And some of the risk factors are having had colon cancer or colon polyps in the past. And we'll go through some of the other risk factors that are both dietary and modifiable risk factors, like certain lifestyle habits. So here are some of the colorectal cancer risk factors. So age over 50, and actually that's now considered even a little, that's outdated now. Actually, it's older age of starting at age 45 is a risk factor for having precancerous polyps and colon cancer. Having a family or a personal history of colon cancer or colon polyps puts you at higher risk for colon cancer. If you have certain genetic mutations that run in your family, that can put you at higher risk for colon cancer. Being African American or Black has been shown to be associated with higher rates of colon cancer. Having inflammatory bowel disease, either Crohn's disease or ulcerative colitis. Having diabetes. Drinking alcohol and smoking cigarettes, and then eating a large amount of red or processed meat in your diet. And finally, obesity has been shown to be a risk factor for colon cancer. Things, though, that decrease your risk for colon cancer that you can do in your daily life: being physically active, taking a baby aspirin every day has been associated with lower risk of colon cancer, having a colonoscopy, removing polyps, and eating a diet that's high in fiber. So meaning fruits, vegetables, multigrains, and also dairy. So things that you can do during your daily life. So maintain a healthy weight. Definitely avoid smoking. That's good for you for prevention of many types of cancers, including colon cancer. Getting regular exercise, limiting your diet in red and processed meat, and eating a diet in high fiber that's high in fiber, and then drinking alcohol in moderation. And the other things that you can do, starting at age 45, you should begin colon cancer screening. So who should be screened for colon cancer? So this is all men and women starting at age 45. through age 75. And even after age 75, you can consider screening up until age 85 if you're still someone in good health. And especially if you've had polyps in the past, we would consider continuing screening up until 85. But it's strongly, strongly recommended to begin at age 45 and go through age 75. Now, the 45 recommendation is something that is new, actually. It used to be that we recommended starting at age 50 for colon cancer screening for all average risk individuals. In May of 2018, the American Cancer Society actually updated their guidelines to suggest that we should be screening people, all average risk people, starting at age 45. And this is based on data that colon cancer incidence is happening in younger people. And it wasn't just the American Cancer Society, they were the first, but then in the last year, all other societies who make these recommendations have come to agree with the American Cancer Society. And so now it's recommended across the board that people should begin at age 45 for cancer screening. And that's a good thing that all the societies now agree, because it means that insurances will now also cover colon cancer screening beginning at age 45 for all average risk individuals. Now, there are some people that should begin earlier than age 45. So I said that people at average risk should begin at 45, but people who are at high risk should start screening earlier. So those with a family history of colon cancer and a first-degree relative should begin at age 40, or they should begin 10 years prior to the diagnosis of that first-degree relative, whichever comes sooner. First-degree relative is either a parent or a sibling. So if a parent or a sibling has had colon cancer, you should begin screening earlier, either at age 40 or 10 years before that person was diagnosed. If you've had polyps in the past because you had a colonoscopy for a different reason before you turned 45 and you had precancerous polyps, then you should consider continuing your screening colonoscopies after that. And then if you carry, you and in your family carry genetic mutations or inherited mutations that put you at higher risk for colon cancer, you should begin screening earlier as well. So what are the options for colon cancer screening? So colon cancer screening, as we said, means checking the colon and rectum for cancer before there are symptoms or problems. Average risk people, as we said, should start having colon cancer screening at age 45. And here are the different screening tests. So there are stool-based tests or fecal tests. There's 3 different options for those, although 2 are more highly recommended. Both FIT, which stands for fecal immunochemical test, or Cologuard are the stool tests that we use most often, or you can have colonoscopy. And I'll go into more detail about these options, both stool-based testing and colonoscopy. So the take-home fecal test, so the other one, by the way, FOBT, which is fecal occult blood test. So a FIT, fecal occult blood test, and then Cologuard. It's when you're given a kit to take home with you to collect your stool specimen at home, and then either bring back to a laboratory or mail it in the case of Cologuard. And the fecal test results, if they are abnormal, then the recommendation will be for you to have colonoscopy. What are these tests test for? So they test for microscopic blood in the stool that you can't see but can be associated with having colon cancer or very large polyp. And then Cologuard in particular tests for both microscopic blood and then also DNA that's associated with colon cancer with a tumor in the colon. So that can be picked up by the stool test. The fecal occult blood tests, you have to be on a specific diet in order for the microscopic blood not to be detected, because if you are eating a diet that's anything with iron in it over the days leading up to you doing the test, you can have a false positive. The other 2 have fewer false positives. That's FIT and Cologuard have fewer false positives. This is a little bit more detail on the FIT test, which is the fecal immunochemical test. As I said, it tests for blood cells or microscopic blood in the stool that can indicate that there's a large polyp or even a cancer in the stool. It's just a one sample, whereas just like Cologuard, there's just one sample that you need. As with FOBT, you actually need 3 samples. Another advantage to this test over the FOBT, and then the Cologuard is the same as well, that you do not need any dietary or medication restrictions while you're giving your stool sample. In this case with the FIT, you use a paintbrush to collect the stool sample and then paint it on a card that you're given. And again, if the test is abnormal, then a colonoscopy will be done. A FIT test should be done every single year, each year. Cologuard should be done every 3 years. So that's how frequently you do the stool-based testing. Now, colonoscopy is a test that's more sensitive. So FIT and Cologuard are very good at detecting cancers when they're at an early stage, before they become symptomatic. So before they're causing you symptoms. They're not as good, nearly as good at detecting the precancerous polyps. And that's what colonoscopy is really good at, in addition to detecting cancers at an early stage. It's an examination when a scope with a tiny camera at the end is inserted through the rectum, and then advanced through the entire colon. And then once the scope is inserted all the way through, then the endoscopist, the person doing the test, usually a gastroenterologist, slowly withdraws the scope and does a very complete and thorough examination for small polyps, and then also anything that might be larger. So it's used to diagnose colon and rectum problems in general. So it's not just used for colon cancer screening. If you had another issue where you had blood in your stool, if you were having lots of diarrhea, we didn't know why. Sometimes we do this test for diagnostic reasons as well, in addition to colon cancer screening. And that's because we can do biopsies of the colon during colonoscopy, and we can also remove polyps. This is a test that can be uncomfortable to have done, and so it is done with sedation. There's an anesthesiologist in the room who gives you medication through an IV so that you're asleep and comfortable for the procedure. The other thing to know about colonoscopy is that your colon must be completely clean, free of stool, for us to adequately do the exam. So you do need to drink a large amount of a liquid laxative prep the night before and the morning of the procedure to clean out the colon so that no stool is left over, so that every surface can be seen, because again, we're looking for small polyps often. And we remove those polyps during colonoscopy. So during the colonoscopy, we're looking both for cancer, but also polyps. Polyps, when we find them, we remove them during colonoscopy. This picture shows you a snare placed around the stalk of a polyp, and then the snare just cuts off that stalk. Very little bleeding occurs, and it's not painful because these are very, very small. The camera magnifies it, but these are typically less than a centimeter, these polyps. Once the polyps are removed, they're sent off to a pathology lab, and we see if they are the precancerous kind or not, because some polyps are not the precancerous kind. They're completely benign and we don't worry about them at all. But if they are the precancerous kind of polyp, then we'll recommend that you have a colonoscopy sooner than 10 years. If you have your colonoscopy and you have no polyps at all, or no precancerous polyps, then you don't need another one for 10 years. If you do have 1 to 2 small precancerous polyps, you're still good for 7 years. And if you have more than that, then we would recommend more frequent colonoscopy, something like more like 3 to 5 years. And so you can see that that 10-year gap is a lot longer than the 3-year gap you're given for Cologuard, or the 1-year gap you're given for the FIT stool test. And that's because this is a much more sensitive test. Colonoscopy finds both the precancerous polyps and colon cancer. And so it's more sensitive. And then just one more point to make, just to really drive home what the advantages and disadvantages are of stool-based testing versus colonoscopy. Stool-based testing, you don't have to go through a prep. You don't need to go through a procedure with sedation. And it's good at detecting cancers at an early stage. but colonoscopy is not only very good at detecting cancers at an early stage, but also detecting the precancerous polyps. And because of that, has to be done way less frequently, every 10 years, as opposed to every 1 to 3. And so those are the advantages and disadvantages to keep in mind. So just to remember, colon cancer can be prevented. All men and women 45 years and older should be screened. Talk to your doctor about which test is right for you, because if you've ever had any symptoms that are worrisome, if you have a family member, even with polyps, we might suggest that you just do colonoscopy rather than a stool-based test. And also, if you have a medical problem where undergoing sedation might be a problem for you, we might recommend that you have a stool-based test instead. But either way, you can lower your risk of developing colon cancer, but also developing later stage colon cancer. And these are just some resources that we provide you with at the end here to call and try to find a place where you can have your colon cancer screening done. And hopefully this will be provided to you by the hosts as well. So thank you, and we'll take any questions now.
Hi, Dr. Kriegel. There was a question in the chat that someone had posed during the presentation, which was, how long does a polyp take to develop into colon cancer?
So it's a great question. Typically, the polyps take longer than 10 years to develop into colon cancer. So that's why colonoscopies are recommended every 10 years. So if you undergo a colonoscopy and you have no polyps, we're confident that 10 years later, you will not have a cancer. If you developed a polyp in the next year, let's say, it typically takes longer than 10 years to develop into cancer. It's more on the order of 10 to 20 years. And not all polyps, I should qualify that. Not all polyps are going to develop into cancer, but a certain percentage will, which is why we remove them when we see them.
That was great. Please feel free to ask your questions, raise your hands, and enter questions into the chat. We'd love to answer more. And we're here for a little bit longer, so let's see.
Yeah, I have a question.
Sure.
Yeah, I know they used to tell us every 5 years for colon cancer screening, but I'm here you saying 10 years.
Yes, so if you have no polyps, 10 years. So if you've had a colonoscopy, so I should qualify. So if you've had a colonoscopy, the gastroenterologist reached the end of the colon, and it was judged by the gastroenterologist that you had a good prep, meaning your colon was nice and clean, and they found no polyps. Then the guidelines say you're good for 10 years. If, however, let's say your prep was judged to be not as adequate to detect all polyps, then they might recommend you have it sooner. And if you had polyps, then it would be sooner.
Thank you. Thank you.
Mm-hmm.
All right, my name is John. How do you prevent you're performing an operation, so therefore you're what should I say, cutting the polyps of the intestine? How do you prevent it from bleeding?
Great question. There are risks associated with colonoscopy. One of them is bleeding if you remove polyps. Typically, as I said, these polyps are small. Most are less than a centimeter. And so they're being removed by very small biopsy forceps. And so very little bleeding occurs. If, however, you have a large polyp removed, you're at higher risk of having bleeding after the procedure and after the polyp is removed. And we have ways to prevent that bleeding. So we have small clips that we can actually place over the site where a polyp was removed. We can close the defect that we created, thereby preventing bleeding afterwards. Also, if it's a large polyp, we can sometimes use cautery to remove it. So we can burn a little bit around the site of the polyp, again, to prevent bleeding afterwards. So we have ways of preventing bleeding. So it's a very good question. There are still a very small percentage of large polyps after they're removed where you could have some bleeding at the site. And that's a known risk, but it's rare.
Right. Thank you.
And then it's a good chance for me to just go over the other risks associated with colonoscopy. Bleeding is one of them. There's a very, very small risk of infection anytime we do colonoscopy, and then a very small risk of causing a tear or a perforation somewhere in the colon, but that's a very rare event. That happens in somewhere between 1 in 1,000 and 1 in 10,000 colonoscopies.
Thank you.
There's a question in the chat, and it says, is there a special diet that would prevent colon cancer?
That's a good question.
Yeah, so a good question. Just things that we discussed in the talk. Just having a high fiber diet and limiting red and processed meats are very good for your gut health, and so that's what's typically recommended. That could put you at lower risk for having colon cancer. It's not necessarily going to prevent it, but it would put you at lower risk.
Hi, doctor. Good night. My name is Dorothy. One of my concerns is after the polyp has been cut, I am assuming, I'm no doctor, but I'm assuming there's an open wound in the colon, and because of its contents, is there a possibility of the contents of the colon seeping in through to your blood?
Oh, it's a good question. So so again, it's very small, these defects that we create by removing polyps, and they heal very quickly. So they're also very superficial. Your colon is nice and thick, and so the polyps that we take out are superficial. And so infection afterwards is quite rare. And again, if we create a large defect because we've removed a large polyp, then we typically will place clips to close that defect, and thereby prevent bleeding and infection afterwards.
Okay, thank you.
I'm just going to turn off my video for a second so I can get a light on. Sorry. You can keep going with questions though.
Other questions for Dr. Kriegel about colonoscopy or the FIT test or the Cologuard test that people have?
So, John again. Only the large intestines that polyps and cancer, whatever the disease, only in that area you could get polyps. What about the small intestines?
It's a good question. Yeah. So it's a very good question. You can develop polyps in the small intestine. It's much more rare. Small intestinal cancer is extremely rare, actually, and so there's no screening that's done for small intestinal cancer because it's extremely rare.
Dorothy again, Doc. A friend of mine did a colonoscopy, and he went to the doctor on the Thursday, and the doctor gave him, well, the thing that you have to prepare yourself with, and had to do the colonoscopy by Monday. But his concern was that he would not be ready by Monday. So he suggested to the doctor that they wait until the following Monday, but the doctor said no. And so the Monday after the Thursday, he went in and did it. But then after it was over, he said the doctor said to him that he's going to have to repeat it in a year because he was not clean enough. And he's very concerned about going back in there 1 year after.
Yeah, so that's something that can happen. It's the most important part of the procedure, I tell my patients, is the prep, because if you do not have a good clean out of the colon and there's still stool left over, then we cannot see everything and the procedure needs to be repeated. If it's a fairly good prep, then we say it needs to be repeated in a year. If it's a not good prep at all, meaning we really couldn't see much, then it needs to be repeated usually within 6 months. So it's very important to follow the instructions that you're given. And if you do have concerns about your prep not being good enough, then yeah, you can always delay your colonoscopy. The things, being prescribed on a Thursday and doing it on a Monday, that's usually enough time. We tell people to start adjusting their diet before colonoscopy about 3 days beforehand to start eating low fiber foods. So I know I just told you to eat high fiber to prevent colon cancer, but before colonoscopy, just for those 3 days, we tell people to eat low fiber foods because those can be harder to clean out of the colon. And so we tell people those few days beforehand to start eating a low fiber diet. So avoiding fruits and vegetables, multigrains, also avoiding seeds and nuts that can get caught up in the colon, but eating lower fiber foods that are easier to clean out. And then when you drink the prep, the important part is, first of all, following all the instructions that your doctor gives you, and specifically doing what's called a split dose prep, drinking half of the prep the night before and half the morning of. You will know if you've had a good prep because in the morning, by the time you're going to your procedure, your last bowel movement should be clear or very light yellow, clear fluid or very light yellow. And that's how you know that you've had a good prep. But sometimes it doesn't happen. And so you need to have a repeat, but there's no danger in having it done a year later. It's just as safe that time when you do it then, but that's up to the doctor's discretion. If they thought that they couldn't see everything, they weren't able to see every surface, so they weren't able to clear you for 10 years. So that's the concern there.
There are some other questions that came through the chat.
Yeah, I can see them. There's one about a shortened colon. So if you have colorectal surgery for some reason, let's say if you've had a large polyp that couldn't be removed on colonoscopy, if you had a colon cancer, if you had a very bad diverticulitis, an infection in the colon that can develop, those would all be reasons to have a part of your colon removed. If you've had inflammatory bowel disease, that's another reason. And in that case, the colonoscopy is easier for us, but we still do it. If you still have any part of your colon left over, we still recommend colon cancer screening. So I hope that answers that question. And then, yes, you can continue to eat red meat, but a diet that's high in red and processed meats is more associated with developing colon cancer than a diet that's low in red and processed meats. So we just, recommend eating it in moderation. So the signs of colon cancer, so signs and symptoms, if you have bleeding, rectal bleeding, blood in your stool, that can be a sign. If you're losing weight unintentionally, that can be another sign of colon cancer. And any change in your bowel habits can be a sign, not always, but that's another thing that can be associated with colon cancer. And then the last thing I would say is if you have blood work, routine blood tests with your primary care doctor, or blood work for any reason, and you're found to be anemic, or you have iron deficiency anemia, it could mean that, you're bleeding for another reason, like, you have heavy menstrual periods, but that can be a sign of colon cancer. What causes food to be stuck in the intestine? So we will sometimes see food impactions, which are present to us in the hospital as emergencies, food getting stuck in the esophagus. That's, if it wasn't chewed up properly, or, if you have an obstruction there. Otherwise, food doesn't generally get stuck in the intestine. It just can take longer to clear out, and that's when you could have a poor prep. But if I didn't answer that question, let me know. But typically, food only really gets stuck if it's in the esophagus and you have some kind of obstruction there, or you didn't chew it enough. Yes, certain foods can affect the results of a FIT test, usually not. The false positive rate for FIT is pretty good, pretty low. It's the fecal occult blood test, the FOBT, that foods can affect, which is why FIT or Cologuard is recommended over FOBT. I believe certain red meats and other foods that are heavy in iron can affect the result of the FOBT. And false positives do exist, though, even, that are not caused by diet, but, there are a certain number of false positives for both FIT and Cologuard, although, the rates are pretty good.
Are there any other condition apart from cleaning out properly that will prevent or can prevent you from getting a colonoscopy?
Yeah, so that's a great question. If you have a cardio or pulmonary issue where your cardiologist or your pulmonologist would prefer you not to get a procedure with sedation, you have severe heart failure or severe pulmonary hypertension, something like that, very, very bad COPD or obstructive sleep apnea, we may decide, if you're average risk for colon cancer, to just do a stool-based test for that reason, because the sedation for colonoscopy may not be suggested. So, but it's only really if you're very sick. We have very skilled anesthesiologists who monitor you throughout the procedure. So, it's only if you have pretty severe comorbidities, like a cardiac or pulmonary one. The other thing is, rarely people can have very, very twisty colons or very, very long colons, and it can be actually hard to complete the colonoscopy. And we won't know that until we've attempted it. But, in order to have a complete colonoscopy, the scope has to reach the very end of the colon. Again, most of the time, a great majority of the time, I would say 95% or above, we reach the end of the colon. But, rarely, you can just have a very, very tight or twisty colon. You won't know that. We won't know that until we do the procedure. One other thing to note, so if you're on a blood thinner, if you, for example, you have atrial fibrillation and you're on a blood thinner, that's not a reason that we cannot do colonoscopy. We still can. We'll either ask you to hold that blood thinner before the procedure, if your cardiologist is okay with it, or we'll ask you to switch that blood thinner over to a medication called Lovenox, which you can inject for just a few days before the procedure, so that you're still getting the benefit, but then you're not at higher risk for bleeding during the procedure. So being on a blood thinner is not a reason to not have colonoscopy. We just, we have ways of dealing with that. And then if you have diabetes and you're on insulin, we just ask you to adjust your insulin dose either the night before or the morning of the procedure, because you're not eating before the procedure. And so, you need to adjust your insulin dose. But again, you can still have colonoscopy. We just make a little adjustment to your medication.
All right. Does a cough has any effect on preventing the colonoscopy? I remember a doctor telling me that during the procedure, he couldn't perform. He saw a polyp and he couldn't take it off because I was coughing and he was afraid that he nicked me. So he didn't go through with removing the polyp.
So things like that can happen during the procedure if, we just can't sedate the person properly and we think it's not safe to do interventions like polyp removal. So yeah, that's possible. It's nothing you can really control though, unfortunately. I imagine they would just maybe attempt it again at a time where, if you had a viral, upper respiratory infection before the procedure, maybe they would wait for a time when you didn't, or they would give you a dose of an inhaler before the procedure to try to prevent the coughing, or they would give you a different type of sedation the next time around. But yes, certain things can happen during the procedure that prevent us from finishing it. If someone becomes unstable or even, coughs too much, then we might not be able to adequately finish it.
Okay, thank you.
I see a question about the recovery time and what you can eat afterwards. So typically it takes about a half an hour to recover from colonoscopy in the location where you are, and then in the endoscopy suite. And then you are able to walk out, on 2 feet. However, we always recommend, and it's actually mandated, it's required that you have someone who escorts you home. A family member, a friend, a driver that you know well, someone who will make sure that you get home safely. And that's because you receive sedation. And so we're actually mandated to make sure you have an escort who will take you home. But you will feel back to yourself. You'll be able to walk out, as I said, on 2 feet, and then feel like yourself within just a couple of hours. You can eat normally immediately following the procedure as soon as you're awake. And in fact, in the recovery area, we give you water and snacks.
While we take the last couple of questions, we have about 5 minutes or so left. Can the exit poll be launched? And people can start answering the poll questions while we speak and we answer other questions. These have been amazing, great questions. Please feel free. We have a couple minutes left. If you have anything that you'd like to ask, ask away.
I would just like to say thank you to the doctors for your outstanding presentation. And my church, I'm Pastor Alan Martin, the pastor of the Christian Fellowship SCA Church that's hosting this. And we just want to say thank you to your wonderful team and the tremendous medical expertise you brought to us tonight. Thank you so much. God bless you.
Thank you so much.
Thank you.
It's been my pleasure. I see another question. Yes, if someone's scared of colonoscopy, stool-based testing is a very good alternative. Any screening is better than no screening. So certainly you should ask your doctor if you're afraid of colonoscopy about stool-based testing. Again, FOBT is not as good as FIT or Cologuard. So I would ask about FIT or Cologuard.
Again, if you have answered the poll questions initially, please answer again if you don't mind. If you did not answer initially, please don't answer now. We like to match the pre and the post to the same people. Thank you. So I'd like to let all of you know before we go tonight that we have a newsletter, our Community Outreach and Engagement Office at the Columbia University Medical Center's Cancer Center. We are going to put the link in the chat momentarily. We also have an email list that if you would like to sign up to receive our cancer prevention newsletter and messages, we'd be happy to have you receive that on email. And it's a list where you sign up and just give us your name and email, and you will get it once a month. And it will be full of interesting and very useful information. That will, Kimberly is going to be putting up, it's up there in the chat already, I'm sorry. The first one that says constant contact pages. that's where you sign up, right? And all right, so they're the same links, right, Kim?
Yeah, it's the same link.
Same link
Yes.
applies. Okay, great. You can sign up and we can send you our newsletter, and it's really good information. Okay, and does everyone see the poll questions up on their screen? Are they visible to you?
That says it was closed or something.
I see it open.
Maybe you should relaunch it.
Okay. And poll. Let's see if we can relaunch it. Relaunch it. Okay. We're relaunching. So if you did have some, are you seeing it now?
Yeah, I see it.
Okay, great, great. So if you answered before a few minutes ago, your answers were erased, unfortunately, because we relaunched it. So if you don't mind answering again, I didn't see any coming in on my end, so I don't know if people were responding or not, but it's ready for you now. And we do have maybe another minute or so for another question. It's 8 o'clock now.
I am clicking submit, but it's not moving.
You may have missed the question.
All right.
Yeah, sometimes on our end, the responses are slow to just pop up for me to see. But I see that 5 people so far, 6 people so far, 7. Okay, they're coming in. Great.
Are there any other questions for Dr. Kriegel or Andrea about colonoscopy or the take-home tests for colon cancer?
Okay, well, thank you all very much. We'll keep the Zoom open a couple of minutes so that you can continue to answer the poll questions. Thank you to Christian Fellowship for having us. We loved being here. We love to see you all again. And be well and stay healthy, all of you. Thank you.
Okay, good evening. This is
Thank you.
Marjorie.
What is the result of the test?
Oh, you want to know the results of the pre-post?
Yeah, the pre-post, yeah.
Okay. Well, Andrea, do you want to give it 2 minutes and then we'll just go over it together?
Yes, for those interested in the answers of the questions, I'd be happy to review them with you. I do see some of the responses still coming in, so people are still responding. We'll give it maybe another minute and a half, and then I can go over, I'll close the poll, and then we can go over the responses. If you would like to know the answers to the questions, we'd be happy to do that.
Well, I'm going to sign off, but it was really a pleasure speaking with you all tonight. Thank you for inviting me. Have a nice night.
Okay, before you sign off, Dr. Krieger, this is Marjorie. I would like to thank you and Andrea and Kimberly on behalf of the Health Ministries Department for being with us, for your timely information, which was so eloquently done, and participation. We thank you ever so much, and we can let you know that what we have learned, we will put it into use and we'll share it with others. And we look forward to having you back again. Thanks again for coming.
Thank you for having me.
Thank you.
Bye-bye.
Thank you. Okay, so I'm going to review these in 1 minute.
So 1 minute left for the poll, and then we'll go over the answers together.
I'm just getting the answers down. don't see, we can end the poll. I don't see any more coming in. So do you still see the questions?
I think you can do share results.
Do you think? I can read them aloud. I worry that doing share results will.
It'll work. I can do it. I'm just okay. Capturing the results so that.
Okay. Yeah, I did. I just captured them.
Oh, okay. So, I think it's sharing the results now, right?
It just says, okay, sure. All right. So question number 1, colon cancer is preventable. The answer is yes. It is. If we get our checkups and we remove our polyps, we can absolutely avoid getting colon cancer. A polyp is question number 2 is, a polyp is something that can turn into colon cancer? Yes. Dr. Kreigel did say that. Not all of them turn into cancer, but some can. That is why when a doctor is doing a colonoscopy and a polyp is seen, it is removed with a little hook. There is only one way. Question number 3 is, there's only one way to get tested for colon cancer. And the correct answer is false, because there are several ways. Colonoscopy and all of the kits, the little boxes, the FIT, the FOBT, and the Cologuard, those are also ways that you can get tested for colon cancer. Question number 4, you can do colon cancer testing at home. The answer is true, right? Because you can use the kit boxes. You take them home and put fecal samples into those kits, either in a vial or spread them on the card, and that gets mailed back into the laboratory. So yes, you can do it at home. What you can't do at home is a colonoscopy, because it needs to be done okay. Question number 5, there are things that you can do to lower your risk for developing colon cancer. Everyone said true. That is correct. There are lots of things that you can do, including diet and getting your checkups and being careful with your health. And yes, so I'm happy to see here that all of you said that all of the people that answered said that this information could help them make better health decisions in the future. This is why we're here. We're thrilled that you answered that way. People here, do you intend to get screened for colon cancer? A lot of people said yes. Some people said no. What will you do with the information that you learned today? And people will be sharing with family and friends, the majority. So we definitely appreciate that. The more you share, the healthier everyone around you can be. And those are the answers to the questions. And thank you all for responding. And anything else before we go?
Any last questions before we leave?
Is there any race that is more prone to get